All right, the lectures today are fairly similar to what you have, except I've cleaned them up a lot and added some extra pictures and hopefully made it a little bit more understandable. Sort of reviewed every single one of these chapters. I know they're a little bit out of sequence with what the book is. Don't worry about that. It's not going to impact your knowledge base. It's sort of when you get the new book, you know, the chapters might be a little bit in different sequence, and I've got these lectures, and I should just call them, instead of chapter 10, I should just call it presentation, whatever. Anyways, the first discussion today is on acute renal failure, and well, let me start one other thing. Today, Megan is going to try to get this up and running by tomorrow at the latest, so these lectures should be available for you to review tomorrow at the minimum. Okay? If you're having any problems, give me an email, and I'll see what we can do. Okay? All right. All right, the first section of discussion today is on acute renal failure. Basically, what is the definition of acute renal failure is pretty important, okay, because as a student or somebody who's approaching somebody with kidney problems, it's confusing as to what the definition is sometimes in clinical, but it's simply an impairment of glomerular filtration rate. What you see with it as a consequence of acute renal failure is that you see a rapid rise in creatinine, okay? That's really the pathognomonic sign of it. Okay, so it takes time to present itself, unfortunately, which means that you could have acute renal failure already, and you just don't know it yet. Okay, so unfortunately, it's one of those things that because creatinine is being metabolized constantly by the muscle, it takes time once filtration stops to start to build up. One of the things that may see a rise in BUN, but a BUN rise does not always mean acute renal failure. So really, the one lab test is going to tell you that somebody is developing acute renal failure is basically creatinine, okay, not BUN. What you see when we have this discussion before is that plasma creatinine concentration is increasing, okay? And if you've got a 0.5 milligrams per deciliter baseline, if you see a 2.5 to 30 milligrams per deciliter decrease, so that's a significant creatinine concentration change. And then you see if it's baseline 1 milligram per deciliter and it's greater than 3 milligrams per deciliter, a measurement of creatinine clearance, it also indicates renal failure, acute renal failure. Now, for you, in the sense that how are you going to have some value like that in the lab, the answer is usually not. So what we usually go by is looking at the creatinine number. If you're, say your baseline is, let's say, less than 1, when creatinine doubles from 1 to 2, that's considered acute renal failure. That person is showing signs of acute renal failure already. They've doubled. They've literally taken a 50% hit on their kidney function. If the creatinine goes from and let's say that you're taking care of somebody who's younger, whose creatinine levels are running at, say, 0.3, okay? If that child comes back with a creatinine back at 1, that kid is already developing acute renal failure, okay? It's showing signs of it. And if it goes from 0.3 to 5 or 4, that's pretty significant acute renal failure, okay? So be careful in the sense of what the baseline is. That's really what's important. And sometimes when you get into clinical, somebody comes into the hospital and their baseline starting is, let's say, 2. So if they go from 2 to 2.5, then acute renal failure, and the answer is no. But if they go from 2 to 4 overnight, that is acute renal failure. You have 50% decrement in creatinine clearance at that point. Okay, so watch the creatinine, the actual initial presentation value. Now, yes. Yes. It's 30. I think it's 3. It should be, let me go back and look at that. I think it was 30 when I remember reading it. It was kind of sounded weird to me initially, but I think it is very high. Okay, but I have to look at it again to make sure, but I think that is still 30. Because it came out of the textbook, unless the textbook could be wrong. So I have to go back and review that. The reason I'm not sure about that is because we never use this value in clinical. Okay, this is kind of a number that people throw out at you in the textbooks, but clinically it's useless. It's like, who cares? Nobody can measure that, okay, unless you do a 24 creatinine clearance, which nobody does. So instead you use the creatinine value as a better indicator of failure. Okay? Now the etiology of acute renal failure is you have 3 possible main reasons. And like I keep telling you guys, knowledge is good, only though to you if you can apply it. Okay? So one of the things that I sort of want you to do, and sort of things I've changed in these kind of discussions, is if I'm a student and I see a patient who gets a creatinine, comes back, let's say their creatinine was at 0.5, now it's at 2.5. How do I take care of this person? How do I figure out what the problem is? And immediately you have to think in your mind, there's 3 possible causes: pre-renal, post-renal, or intrinsic renal disease. Those are your 3 categories you're going to look at right away. The 2 easiest ones to deal with are pre-renal and post-renal. Okay? So you want to try to identify what the possibilities for those 2 areas are first, and immediately try to take that off the shelf. Get rid of the problem. If you can solve it by taking care of those major issues, then the person starts getting better. If it's the last one, which is intrinsic renal, then you've got to start looking for all the possible causes of intrinsic renal, which, by the way, are a lot more difficult to manage. Okay? So acute renal failure is multifactorial, like it's shown here. Okay? Either one of these will cause acute renal failure, which leads to decreased filtration and increased creatinine. Okay? So when you see the terminology telling you somebody, okay, the person's developed acute renal failure, it's not designating where the disease process is taking place. It's not telling you if it's pre-renal, intrinsic, or post-renal. It's like a generalized statement. Okay? If you think it's intrinsic renal, then we'll show you into the different values. You can go look at glomerular, vascular, or tubulointerstitial disease, and then we'll talk about pre-renal and post-renal obstruction here in a second. Okay? I think this is a much more helpful way of looking at it clinically, and that's why I've included this in picture. Okay? And I'm going to go over it again in more detail. When somebody develops acute renal failure, in other words, their creatinine begins to rise, you need to be able to break it up in your mind into these 3 major components: pre-renal, post-renal, and intrarenal. The only reason I don't like this one is that it doesn't give you the hierarchy of what you need to do. So what I've done for you in the next slide was do this. How do you diagnostically approach this? And the answer is, if you have new onset oliguria, which means that urine output's falling, and if you had the luck of looking at creatinine and you see it's rising, okay, you need to do basically a kind of a history and physical. Okay, make sure that the person hasn't had a new medication added. Make sure that this person's not in shock. Okay, make sure you get a real good history and do a real quick physical on the individual to give you a better way of diagnosing this problem. The first thing after you do that is then you exclude either pre-renal or post-renal etiologies. That's the key. And I can say pretty much for us, almost 90% of what we have to deal with in the operating room is pre-renal. So you should be able to have that differential in the back of your mind. What does pre-renal mean? Okay? And the pre-renal can be broken down as I'm not delivering enough oxygen, okay, which just means that person could be hypoxic. I could have an inadequate vascular tone, either I can vasoconstrict the renal arteries inappropriately, or I could have somebody put a clamp on the aorta, something that basically impedes blood flow to the kidney. Okay? I could have a person with a low cardiac output, so a person who's in congestive heart failure, cardiogenic shock, septic shock. Okay? A person who has basically low effective volume, which is about 90% of what this is. Most of this problem in our world that we live in is low effective volume. Most problems are low effective volume. Now what that means by effective volume is another way of looking at it is preload. How much preload is arriving at the heart? So if I'm actually intravascularly okay, but my preload is still low in the heart, can that happen? How could that happen? Right, positive pressure ventilation. If I put too much PEEP on somebody and I squeeze the heart down, the preload return's not getting to the heart. So preload is reduced. So that's called low effective volume. Okay? And then you can also have vascular obstruction, which I just said to you, which is like a clamp, or you could have thrombi that could fly, or embolus that go down to the renal arteries. The other thing you need to do is you look at the other way of looking at this is look at the postrenal areas, and that could be from urethral obstructions, patient position, urethral or catheter obstruction, which we'll talk about in more detail here in a minute. And then the last thing, if after you give volume loading to both these people and do some other things, if that still doesn't solve the problem, then you start looking at intrinsic disease processes. But literally, the first thing you're going to do is give volume most of the time. Okay? If the volume doesn't respond, then you got to start thinking, what's going on? Why is it not happening? Why is the urine output not increasing? Because if I make you guys all drink 4 cups of coffee right now, okay, each one of you, you wouldn't last 20 minutes in here, okay? Because whatever I gave you, you're functionally getting positive input, so you're going to want to go urinate, okay? And that's what should happen when you give fluids. If I give you a loading dose of fluids, let's say I give you a liter of fluid, how much fluid should you expect that person should urinate? One liter back? No. This is putting things together for you. When I give 1 liter of crystalloid, okay, it's going to go into 3 compartments. The vascular compartment, and there's 2 compartments that are right next to it, which is the interstitium compartment, that are the same volume. 2 compartments in the interstitium is basically going to soak up that fluid. So basically 66% of the volume that you just gave is going to go into the interstitial space. The other 33% is going to go into the vascular space. Okay? And if you're going to filter that, 60% of that will be filtered. So 330, 60% of that. So you're looking at maybe 200 cc's of urine output you'll have in an hour. Haven't you ever seen that? You've given a liter of fluid and all you get is 200? You wondered why? Where the heck's the rest of it going, right? That's where it goes. It distributes out very quickly. Okay? So just keep that in mind. Now, when you drink fluids, the same thing happens. It will distribute to all the cellular spaces, but it immediately goes into the interstitium and the vascular space right away. All right, so pre-renal workup is pretty important. Okay? You don't want to let this person stay, and this is where kind of important, and the books doesn't really hit you with it. It sort of plays it around the edges. Pre-renal problems, if you don't treat them quickly, will be developing into intrinsic renal disease or complete renal failure. So pre-renal syndromes, don't take it lightly. Even though it's just volume, it can be solved pretty quickly, yes, but if you let that person stay for that too long a period of time, it's a progressive disease where you start getting structural damage of the kidney. So it goes from pre-renal, where it's before the kidney, to become an intrinsic renal problem because you waited too long. Okay? Now here's the actual 3 major reasons for pre-renal issues. Absolute decrease in extracellular fluid volume, decreased renal blood flow, and altered intrarenal hemodynamics. Okay? Let's go, I'm going to go into the, yes? That's a good question, and it depends. Depends on the situation you're in the sense of what is the person's profound level of shock, how much hypoxia is really taking place in the bloodstream. If you have somebody with rich oxygen source, even though they may have a low perfusion, they may still be okay. But if you have a combination of low oxygen levels and low perfusion, the person's intrinsic renal disease will show up very quickly. They'll develop the next stage, which is called ATN. Which is acute tubular necrosis. ATN is basically it's an intrinsic renal disease. It's inside the kidney. Okay, so that's a good question, and it's a very hard answer to have. One of the things that you should always do to somebody that you're seeing urine output drop off is you should make sure that you're delivering enough oxygen. Okay, you want to check. Okay, make sure your PO2 is okay. So, anyways. So the first 2, I'm not going to go into a lot of detail because we've already done this a lot in cardiac. Okay, so basically, if you solve the cardiac problem, which is the extracellular fluid volume is not adequate, you check your volume status, look at your neck veins, put invasive monitoring and give fluid challenge, would usually resolve that problem. Okay? If you have actually decreased urine output, decreased renal blood flow, it could be from heart failure, or it could be from things like arterial compression, or the aortic cross clamp, or renal artery stenosis. Either one of these are kind of things that you've got to sort of work up and figure that out. Okay? And the last one is where I'm going to go and spend a little more detail in, is because this is not related not so much to the heart and volume, but rather what's going on with the kidney itself, which is the altered intrarenal hemodynamics. Drugs can cause problems with afferent and efferent arterial control. They can also, sepsis, hypercalcemia, hepatorenal syndrome, and abdominal compartment syndrome can all alter your intrarenal hemodynamics and basically cause a preload failure, pre-renal failure. If you look at renal artery stenosis, so I sort of skipped the first two, okay? Now I've actually gone to, actually not the first two, but the first one I skipped through. The second one I'm here now. I'm starting at renal artery stenosis here. That's what the next slide's at, okay? Renal artery stenosis is a progressive disease that takes many years to develop, usually. It can become more aggressive in changing your diet at times. The problem with this disease process, it is an inflammatory mediated reaction that leads to ultimately damage to the lining of the aorta and to the renal arteries. As it progresses, it begins to occlude the renal artery itself, and the kidney begins to starve itself for volume, for enough perfusion. The way the kidney reacts to it is to produce high levels of renin because it perceives that perfusion is low. And as a consequence, it drives angiotensinogen up to, and then converts angiotensinogen into angiotensin 1, angiotensin 1 to convert into angiotensin 2, so your angiotensin 2 levels are very high, which then causes the intense vasoconstriction of the efferent arteriole. Okay? Now, what angiotensin 2 is basically doing is it's vasoconstricting this efferent out, and even though this is decreased over here, you're still maintaining adequate perfusion pressure inside the glomerular capillary, and you're still maintaining filtration. Okay? Of course, if you give too intensive angiotensin 2 levels, then the efferent completely vasoconstricts and you lose all perfusion. That's not good. So you don't want to do that either. It does make an increase in SVR, makes patients hypertensive. And so this is a nice picture showing the progression of the renal artery stenosis, showing that the aorta is very intimately involved a lot of times. What we do nowadays for treatment of this is we actually will put in stents inside the renal arteries, and this is done by interventional radiology or by vascular surgeons using interventional techniques. Now, this is kind of a busy one, but I thought that was kind of helpful. And what I've done is I've color-coded it for you into showing you what the effects are. If you look at renal sympathetic nerves, when they are stimulated, it causes the afferent as well as the efferent arterioles to increase in their resistance. This will decrease your sodium filtration pressure, and ultrafiltration coefficient will drop as well. And then your effect on GFR overall is negative. So everything on the red box is not a good thing. So renal sympathetics, when it's too intense, it's not good. Okay? Now, if you think about it, the next one kind of makes sense with you also is epinephrine and norepinephrine. Those are neurotransmitters similar to renal sympathetics, so why should they be any different? And the answer is they're really not. Okay? The ultimate effect in here, which is what we look at, is GFR, is reduced usually when you get especially high doses of epi and norepi. That's why, especially norepi is bad news. That's why leave-em-dead is called leave-em-fed is usually called leave-em-dead because it can cause such intense vasoconstriction of the renal arterioles that you'll lose all blood supply to the kidney, and that person can actually then develop renal failure. Angiotensin 2 is a much more prominent vasoconstriction on the efferent arteriole, and it does help on your net filtration pressure, so that's a good thing. The downside to it is your overall effects on GFR is reduced. The only good thing that you can see here that actually increases GFR, and also down here, which is dopamine, is ANP. ANP tends to decrease your afferent arterial resistance, okay, and gives you better filtration as a consequence. The prostaglandins are really helpful, not so much for overall effect. in the sense that they're inhibitors of this, of epinephrine and norepinephrine. Okay, so when you allow prostaglandins to be released, which is what the kidney usually does when perfusion drops off, it will reopen the vasculature and will offset the effects of the sympathetic nerves as well as epinephrine. So you cannot give people this they're in shock, like things like your non-steroidal anti-inflammatory agents. Okay, so you can just look at this on your own time. This gives you a little bit of an idea the value of some of these things. Now, renal artery stenosis and ACE inhibitors. The ACE inhibitors basically reduce your SVR, and they've been found to reduce your cardiac risk. And also, what it's also been found is that it actually induces regression of the renal artery stenosis. They're trying to find out why that happens. It's still not clear. It has to do with something with apoptosis. It sort of ameliorates the apoptosis. ACE inhibitors are also known to stop remodeling of the heart as well. So it's something that it's doing just besides vasodilation and its effects. It's having some other kind of DNA effects in the cell. Therapeutic intervention prior to eventual decrease in renal perfusion. Okay, so one of the things that we see that you don't have to, in patients that have renal stenosis, if you give them low doses of the ACE inhibitors, it doesn't necessarily drop the blood pressure down as much, but still protects the kidney by regressing the renal artery stenosis, which is kind of a good thing. Okay? The only bad thing is if you give it at too high doses, it will induce a complete renal failure. Okay? If you can cause the blood pressure to drop too quickly in somebody who has very high levels of renin being secreted, like in this situation, this is usually end-stage renal artery stenosis. So in other words, if you have somebody who came in with very significantly hypertensive, he's got no diagnosis, you would not want to start him on ACE inhibitors until you had a diagnosis of renal artery stenosis or not. If that person had, let's say, 90% occlusion on both bilateral renal arteries, it would be a bad idea. You could push them into renal failure rather easily. But if they're on the early disease process, giving them the ACE inhibitors may stop the progression of the disease. So you got to be sort of selective with patients. Your non-steroidal anti-inflammatory drugs, remember angiotensin and norepinephrine leads to an increase in glomerular production of prostaglandin. That's the feedback loop that sort of activates the release of prostaglandins. Remember, these guys are causing intense vasoconstriction, especially on the afferent side of it. So when these guys get activated, they release increasing levels of prostaglandin from the glomeruli. You get prostacyclin and PGE2. These prostaglandins inhibit renal vasoconstriction, so it maintains renal blood flow. But if you give that person NSAIDs, you inhibit it, which we talked about in the nauseum. So the reason I'm hitting you so hard on this is because I don't want you making a mistake. Do not give these people Toradol, please. Okay, you're going to get somebody going to renal failure if you do. Patients at risk are the ones that have elevated norepinephrine and angiotensin levels, so your diuretically treated patients, true volume depleted patients, patients that are in congestive heart failure, and patients with hepatic cirrhosis. Yes? Say it one more time. The prostaglandins, are they only released in the renal vasculature? Is that what you're asking? I'm not sure that it's not somewhere else in the body as well. Okay, but the only ones that we tend to talk about for end organ it's because the only organ in your body that has two arterioles really coming in and out is the kidney. That's really the basic mechanism behind that. If it's somewhere else, it could be, but nobody really talks about it too much that I've seen. It could be in the brain, but I'm not sure. It'd be a good research topic if you're interested. Okay. Hepatorenal syndrome is a combined liver and renal failure. Okay, and this is kind of a really bad one to have. If you start developing renal failure, with already somebody who has cirrhosis, it rapidly progresses over the 2 or 3 weeks, and then the patient dies. So mortality rate is almost 90%. So you've got to sort of pay attention. If you see somebody with cirrhosis, you've got to be very cognizant that you can't let the kidney shut down on you. Things really can happen that are really kind of bad. Okay? And what actually induces the renal failure is really unclear. Nobody really understands the mechanism. They had a really good review about this in the New England Journal of Medicine, I think about 2 years ago. And I can maybe pull that article up one of these days. But it discusses about the hepatorenal syndrome in a little bit more detail. The hepatic cirrhosis leads to what's called marked splanchnic vasodilation, which leads to a reduction in SVR and a reduction in blood pressure. The other thing that happens with cirrhosis is that your liver becomes like a dam. It doesn't allow fluids from the portal circulation to come out, so it begins a back pressure, and the volume begins to be extruded out, developing ascites. Okay, so these people develop an effective volume depletion. That effective volume depletion leads to several things. It leads to an increased level of angiotensin II, as well as an increased level of aldosterone. So the body's trying to retain excessive amounts of sodium and as a consequence hold more water in these individuals. And they also have increased levels of norepinephrine in their bloodstream. This will eventually lead to a decrease in renal perfusion and leads to a decreased levels of GFR. So liver disease leads to a reduction in urea levels and a reduction in creatinine levels due to the lack of protein production. So sometimes you can be fooled into thinking the kidney's doing okay because just literally the urea and creatinine are not being produced in high amounts. And all of you have seen patients that have very bad cirrhosis. They come in, their bellies look really large, right? So that's where your eye tends to go. It tends to go to the belly and it goes to the person's core. But here's where I challenge you. Look at their arms. Okay? Look at their, and these are men a lot of times, okay? If you look at their mass on their arms, they're really thin. Their muscle is almost all gone. It's down to the bone. The reason that's happening is because this problem. The liver cannot produce proteins anymore, so with the proteins levels when become depleted, the body begins to steal it from other areas, and that includes the muscle. So you'll start seeing massive muscle wasting over these individuals over time, and eventually their creatinine production levels are really low. So you can think that the kidney looks okay because your creatinine coming back, let's say at 1, but in reality, if you had real creatinine being delivered, that person's creatinine could be as 2, 2.5. Because that's how much muscle mass you've lost on this individual. Okay, so you've already got a setup of somebody who's already in renal insufficiency, and can you push them over the edge into renal failure pretty easily. This is a nice picture. This comes out of that New England Journal article. Basically shows you how the actual cirrhotic patients are at, and how the splanchnic circulation is severely vasodilated. Okay? And you get a marked reduction in a basically effective arterial blood volume, and leads to sodium and water retention and ascites formation. And that can induce some activation of vasoconstrictor system and impairment of cardiac output, which eventually leads to renal failure. Now, if you start seeing that the person has advanced hepatic disease and the plasma creatinine levels are higher and they're beginning to go up, you should cancel that case immediately. That person should not go to the operating room until you figure out what's going on. Because if you take that person to the operating room and they become volume depleted and you push them over into the edge where now they've developed frank renal failure, the mortality rate's at 90%. Okay, so you've got to be really careful watching that. If the person tells you, well, I got a creatinine of 2 and 3 weeks ago it was 2, then that's a stable condition, but that person is really high risk for not doing well. And you've got to do everything you can to monitor that person very carefully. A-line, you need to consider putting a central line, make sure that the person is adequately volume, and be very careful with positive pressure because these people will fall apart on you. Why would it be worse with a person with liver disease to fall apart on you? You're volume depleted, for one. Okay, the liver is already congested. Okay, if you put positive pressure, what happens to the inferior vena cava blood flow? It goes down and actually could stop. Okay, and if it stops, 50% of oxygen delivery to the kidneys through the portal circulation. So now you've made the liver even shockier. Okay, so that's the kind of things that can happen pretty quick. Okay, remember, venous return can be significantly impaired in the liver. Okay, just with positive pressure. Because what's the pressure like? It's like maybe 5 to 10. What's your PEEP at? Or your mean airway pressure? 5 to 10. So you're almost basically going to 0 portal vein flow. All right, one of the things that will happen is this person doesn't resolve, is it gets severe encephalopathy and increased risk of variceal hemorrhaging. Management is basically to exclude other causes of renal failure, which is always the case. Ensure adequate volume status, avoid nephrotoxins. Paracentesis is also sometimes a very good idea because you can drain the fluids, because these people develop almost like an intra-abdominal compartment syndrome. So you drain the fluid out and all of a sudden they start urinating again. The reason that's kind of counterintuitive is because when you drain the fluids out, you're going like, I'm making the person more dehydrated, right? Why is their urine output pick up? And the answer is that you've decompressed the renal vein. The renal vein now resumes its blood flow, and now the filtration can continue through the kidney. Okay? And you can tell, people that have really tense ascites, literally you can look at their belly. When you pull up their shirt, their belly looks translucent. Okay? The skin almost looks pearly. It's so tight. That's usually when you need to consider doing this. Okay? The other thing that some centers are doing now is that they're adding other things like octreotide, albumin to the treatment, or they can even consider doing renal replacement therapy in some of these individuals. The next thing is post-renal workup, which again, this is something that everybody expects you to know. Magically, I don't know how it is. Magically, we expect people to know this, but everybody says, it's easy. It's a mechanical problem. You'll be able to figure it out once you get there. Okay, well, let's take a look. Post-renal, the most common obstruction of these four is the fourth one. It's a urethral obstruction. And it could be from prostate enlargement, which is the most common cause. And there's many reasons why the prostate becomes an issue. We're giving medicines in the operating room that can cause the prostate to constrict down and can cause urethral obstruction. Okay? Now, most of the time we don't notice that because we have Foley catheters in individuals, but Foley catheters can be very nasty things. Okay? So the other ones, of course, are bladder as you're going up ureter and then post-ischemic obstruction. It's really a common anesthesia problem. The first thing you got to ask is the Foley in the correct place? And everybody says, well, it's a simple tube. It goes into your bladder. Okay, how could it be in the wrong place? Well, I've seen people put it in the rectum. I've seen people put it in the vagina. Okay, I've seen one put in the uterus. My personal favorite is inflating the balloon in the prostate. Okay, it's not a good day. Okay, now. So you can have it in really a lot of places. I've seen actually Foley catheters be twisted in half, and the Foley was bent 90 degrees. And the only reason we know that is when they tried to put the wire through, the wire couldn't get through it, and they shot dye into it, and then it was bent inside the person's urethra. And it could explain why the guy was screaming for the last 2 days, okay? And why he had no urine output. So it's things like that that people would think about no way possible it can happen. It can happen, okay? The other thing that can happen, too, is if you're traumatic, you can form a new urethra, which is called a false lumen. And that's very bad, too. Okay, you're not going to get any urine output. All you're going to get is blood back. So if you see that, that's not a good thing. Okay? So the question is, what do you do? In clinical, what we tell you to do is watch what they're doing. I always watch when they're putting in a Foley. Okay, just make sure that they're not having problems. Just look over their shoulder. Look at it real quick. If they're doing the jamming thing or something like that, tell them stop. Okay? It's time just to wait and get somebody else, which is usually the urologist will come in. And a lot of patients have problems in our department because we're taking care of 80-year-olds. A lot of people have BPH, so they're difficult to put in. Or you switch over to Coude's, or you use what's called a Urojet. How many people have seen a Urojet? Urojet's basically lidocaine. Okay? And what we do is we inject lidocaine into the urethra and dilate the space, and you keep the Urojet in there, and it makes a dilated space, and then you put the catheter in, and it goes right in. So it makes a difference. Little tricks like that. Okay. Now, is a tube going to be kinked? Okay, it's a possibility. One of my favorites was the surgeon was in a rush. He put the Foley in for us. Then we put the Foley tubing there for us. Everything was great. And then they decided that needed the arm board back on, so they put the arm board on. And in the middle of the case, like, where the hell's urine output? There was urine a little bit when we saw it go in, so where is it at? When they put the arm board in, they compressed the Foley tubing. So the thing was completely occluded. And by the way, it was cut in half. So there was, when we unlocked the arm board, the urine just poured on the floor. Okay? So, stupid stuff. If you don't go look, okay? Because what happened was, why did this person, the next thing that happened was the person had no urine output. The person saw a little bit of urine go into the bag, which initially went in, which is fine. So they thought there's something wrong. So they gave this guy 3.5 liters of fluid. Well, he had about 2 liters of in his bladder. It was about to explode. Okay? So, don't do that kind of stuff. Always think mechanical first. Did he get it inserted properly? Okay, it's in the right place. Okay, and then walk the tubing all the way back to your emitter bag. Okay? And then also check the height of the bag. I had another person where they put the Foley bag and they put it on the pole, on the IV pole. And then when they did the procedure, the person's position was switched where the bladder was below the Foley catheter bag. And they weren't getting any urine output, and they're going like, why isn't urine output coming out? Can't go anywhere. Can't come back upstream. Okay? Little stuff like that looks silly, okay? But it really makes you really look stupid when you're in the clinical area and you're the one that did it. Okay? And I can tell you, each one of these stories is a true story. Okay? My personal favorite one, of course, is the student that kept asking the patient to open their eyes. And I was patiently just waiting, and I just couldn't stay any longer. And I said, you know what might help, son? And he goes, what? I said, take the tape off his eyes. So, it's called epinephrine in your brain. You don't recognize. I don't know if he was blind or something that day. It just, I was a little worried, but he was a good guy. He ended up doing more. Anyways, approach is watch when the Foley is placed, ask if you had any problems, look to see if any of your urine is flowing in the tubing, and then walk the tubing back. Make sure the bag is below the bladder, and then if something's not going on right, then check the bladder. Okay, see if you can palpate the bladder edge. If you have instrumentation like a bladder scanner, great, get it. Okay? To stand it with no urine, ask for Foley to be replaced. That's what I do. If you don't have when you do a bladder scan and you see the urine is the bladder's huge, and the Foley's in the wrong place no matter what anybody says. Here's my favorite one. Foley went in, everything was perfect. Then 2 hours later, the person is just very uncomfortable after awakening and says, I can't urinate. Okay? And look at the urine output. It's just like trickling. Okay? Bladder scan, full bladder. Okay? So what do you do? And everybody says, no, just leave the Foley in, it'll be fine, it'll drain. I said, no, take it out. Took it out. Okay? When we took it out, when we looked at the Foley specifically, the actual hole size for the entrance, for the urine, was 1/10 the size it should have been. It was a manufacturing error. So it was like it was coming through like a little filter, like a toothpick hole. So it was never going to come out. So up against the guy's bladder wall, it was never going to get Foley. Soon we put the other Foley in, 2 liters dumped out of the guy's bladder, which we had a clamp at 1 liter. You don't want to if a person has 2 liters in their bladder, clamp the tubing at a liter. Okay, do not let the person waste 2 liters. Do you know why? You get urine, what's called urine atony. The bladder atony. The bladder will not compress anymore. It'll stay that way for hours or days. So you don't want to do that. Just empty it slowly so it can compress back down. Because what happened at that point was the bladder was so distended that the ATP in that muscle became depleted. And if you let it squeeze all the way back down too quickly, you get what's called atony. Not good situation. So just let it go. Maximum you should allow it coming out 1 times a liter. Okay? And also, you could be having something like bilateral ureteral obstruction, but that's really very, very rare. Sometimes if the bladder's completely empty, the next thing you should think of, I got a pre-renal or intrinsic renal problem. Because if I got no urine in the bladder at all, and I got no thing in the Foley, I've got a problem with filtration and fluids not getting down to the ureters. Now, there's a possibility that you may have a stone on both sides, but the chance of that happening is pretty rare. Okay, now you could have one kidney only functioning, and then it has a stone on that side, and then you have no urine output. Usually you'll know that ahead of time, the surgeon will tell you. Okay? But otherwise, if you see that you think somebody's got bilateral, good functioning kidneys and no urine output at all, then you've got a problem inside the pre-renal or intrinsic renal process. So let's look at intrinsic renal. Basically, intrinsic renal is usually, most major causes of it is pre-renal. It's It's a shifting over from the pre-renal to the intrinsic renal disease. So what you do usually when you think that something's going on is you give a volume challenge, then make sure you optimize cardiac performance, and then make sure that you have adequate renal blood flow. And 75% of acute renal failure is due to pre-renal problems. Okay, I think in the operating room it's almost 90%. Okay, but overall, everybody that comes through the door to the hospital that comes in with acute renal failure, 75% is pre-renal. That's why everybody gives volume. Haven't you ever noticed that? You guys worked in the units. What's the first thing that people do when their urine output's low? Volume load. Give them 500 to 1,000 cc bolus. Okay? The end process is if your pre-renal problem is not corrected, this will lead to intrinsic renal disease, and that means acute tubular necrosis, ATN, which is really bad. Okay? What causes ATN? Lack of oxygen. Okay? You can also have, these are the four major causes of ATN: post-ischemic, transfusion reaction, excessive ADH, and toxic. The most common one is post-ischemic, from lack of perfusion. Okay? It can cause by anything: hypotension, hypovolemia, septic shock, or due to decreased oxygen delivery. If you're not giving oxygen delivery, you fail your job miserably that day. Okay? I mean, that's something you should be checking all the time. So that should be almost like a non-ever happening. In other words, the person should never come in hypoxic in the operating room. If you've got a pulse oximeter, you're drawing blood gases, there's absolutely no reason that the person should be hypoxic. Okay? And if it is, you better treat it quickly so you don't get in this problem. Now, could a person get anemic? Yeah, but you've failed your job of monitoring properly. You're not really watching as carefully as you should have, and you should not get them to the point that they're going to become anemic. If you see the damage pattern that you see with ischemic ATN, is that the proximal tubule as well as the ascending portion of the loop of Henle is where the damage is taking place, as well as some portions of the distal convoluted tubule. But most of the damage is still in the proximal tubule and the ascending portion, the thick portion of the loop of Henle. If you look at the transfusion reactions, that can occur because the binding that takes place, and you kill all the blood flow and all filtration stops, and then the vasa recta get full of this kind of junk, so you don't perfuse, and you get this kind of injury as well. Excessive ADH is from intense efferent vasoconstriction. Remember, ADH is pretty potent at that. And then toxic ones, it's kind of a mixed bag as to what causes it. And depending on what the drug you're talking about, what ends up happening if you give somebody antibiotics, especially things like vancomycin, gentamicin, all the mycins in other words, okay, or you give somebody acyclovir, or you give them dye, all that stuff gets filtered. Okay, so it passes through the glomerulus. Because they're molecules, though, your body immediately tries to reuptake them. It doesn't really recognize that they're bad or good. Okay. So when it uptakes it, it begins to uptake it in where? Proximal tubule. Okay? Proximal tubule levels, it gets so high inside this areas, the vacuoles that it sucks it up into, that it reaches what's called toxic levels, where it begins to cause lysozyme activation and the cells go into what's called apoptosis. So you can see in this picture, most of the damage from toxic medications and all the immunosuppressants and neoplastics, all that stuff, and certain antibiotics will cause proximal tubular necrosis. Okay, and it's very, very bad. It denudes the wall completely. You get debris, and it completely clots off your actual tubule inside. So the things that lead to ATN are decreased cell ATP stores. The kidneys are very high risk. Okay, remember 20% of the cardiac output, so it's a big oxygen hogger. The medullary ischemia is the area receives less than 10% of the total renal blood flow, but areas at most risk are the ones with the greatest metabolic workload, so the terminal segment of the proximal tubule, as well as the ascending thick loop of Henle. Altered metabolism, membrane phospholipids, may also be another reason. These toxic metabolites can also cause generation of free radicals. And there can also, as a consequence of that, you get cell attachment. Basically, the actual tubule, the cell that's attached to the base membrane, basically apoptoses and peels away. And when it peels away, it forms like little cell fragments that are now clotted inside your tubule. This causes denuding of the epithelial cells. Okay, tubular injury tends to be most prominent in the proximal tubule, which we talked about. It leads to occlusion of the tubular lumens by cellular debris, and if it completely occludes it and no more urine can go through, that nephron dies permanently. You can't get it back. So what do you do if you have somebody with this kind of problem? And the answer is you got to flush the kidneys. You got to keep the kidneys flushing. You got to take that debris and flush it through. The way you find this is when you draw urinalysis, you'll get a cast formation. The cast formation can be seen with hemolysis or rhabdomyolysis, okay, caused by precipitation of heme pigments. Okay, that's one reason you get cast. But in these kind of things, you'll see from the actual the cells themselves, you get cellular cast formation. What eventually will happen is it causes tubular obstruction. You get back pressure on the glomerulus, so filtration stops, and you get increased reabsorption of both urea and creatinine. Okay, so the consequence, excretion for creatinine drops off dramatically, which is why it rises. Proximal tubule damage basically gives the inability to reabsorb sodium and water, so the person begins to waste sodium in their urine, and you also will get increased water loss, because remember, water goes where the salt is. Okay, so these people become effectively dehydrated and hyponatremic. So what are you going to see in what's the differences? See, and this is why it's important to understand this. This laboratory finding shows you the first presentation if it's purely pre-renal. If you wait too long and don't treat it, it's going to go into ATN, which is basically intrinsic renal problem. So this individual comes in with a BUN creatinine ratio greater than 20:1, but if you wait long enough and start impairing the creatinine reabsorption, it starts causing this increase. They go up both together, so both the BUN and creatinine sort of go up together in an equivalent ratio, so you get a 10:1 ratio, less than 20:1. If you look at your urinalysis for pre-renal, you don't get cast, okay, or very few cast. This one get lots of cast, and it's all the granular cast from the renal tubular epithelial cells. If you look at the pre-renal, sodium is very tightly controlled because the proximal tubule is not damaged at that point. So it's holding the sodium in, it's holding the water in, so the fractional excretion of sodium is very low, and the urine osmolarity is very high. So that person is basically holding the water in, very concentrated urine, versus somebody who's developing ATN, it converts into a salt wasting situation, so urine sodium all of a sudden rapidly rises, and then your fractional excretion of sodium in the urine rapidly increases as well, and then you get the urine osmolarity drops off like a rock. So this person becomes now dehydrated. Treatment is to decrease your tubular sodium reabsorption, so you want to maintain diuresis. You want to wash out the obstructing cellular debris and cast. So what's usually done at this point is somebody's given fluids at a certain maintenance rate to prevent this from progressing. Then some people will give loop diuretics. Loop diuretics restore a more favorable balance between energy delivery, because what they do is they shut down the ascending loop of Henle from functioning anymore, and it decreases the cellular activity of that area, so that portion of the nephron is more protected. The proximal tubule, though, still is not protected. It's only the other portion of the tubule, the distal, the ascending loop of Henle, is being protected by the loop diuretics. Okay? The proximal tubule still can take a whack. Okay? The oxygen, but what you're doing is you're shutting that area down, and the oxygen that you may have is now it's going to go to the proximal tubule more selectively, because that's still going to suck up the oxygen. So maybe you might have enough oxygen to keep it alive. That's the thought process. Okay? Loop diuretics may promote cell preservation by diminishing area requirements. That's what I was trying to say. By up to inhibition of 45% by the active sodium chloride reabsorption. So that's a pretty significant decrease in activity. The other thing that a lot of us will try to do is give mannitol. Mannitol has several things. One is it's an osmotic diuretic, so it keeps the tubules from being overwhelmed by cast. And the other thing we like about it is, I like about it, is it's a free radical scavenger. And especially when you have metabolites like aminoglycosides and things that are damaging the kidney, I think the free radical scavengers can be helpful to sort of take out some of that stuff and sort of sweep it through the urine and get it out of the body. The other thing that people are using is they're using ANP, which is a H1-natriuretic peptide, which increases the GFR by direct effects on glomerular arterial resistance. But it must be given with dopamine or mannitol to prevent an undesired fall in blood pressure, since ANP is a direct vasodilator. So I personally have never done ANP myself. The book says that people do that. I don't know. I guess not where I trained. Okay? We kept it pretty simple. I mean, anytime you start adding more stuff, it just can really mess things up.